Hello, everyone, and thank you for joining the HPTN 094 Integral webinar. My name is Jonathan Lucas, and I'm going to be just giving a few ground rules before we get started and turn it over to our moderator, Annette Davis, for today. All lines are muted, so if you have questions, please use the chat feature to ask those questions. We'll be trying to respond to questions real time. And there will be, after our speakers speak, time to take questions live. This presentation is being recorded. The slides and the recorded webinar will be posted on our website, www.hptn.org, sometime next week. With that, I'm going to turn it over to your moderator for today, Annette Davis.
Hi, welcome everyone, and I'm so thrilled that we are able to have this webinar this afternoon for where I am here in Philadelphia. And I'd like to introduce our presenters. Dr. Stephen Chaptal is the protocol chair for the HPTN 094 and professor in the University of California at Los Angeles Departments of Family Medicine and Psychiatry and Biobehavioral Sciences, and professor in psychiatry at the University of Cape Town. He energetically leads research, clinical, and policy efforts that bring novel and high-impact strategies and delivering cultural competent care and prevention for persons affected by addiction and HIV. Dr. Chaptal also maintains a limited clinical psychology practice at UCLA, treating severe substance use and mental health disorders. Dr. Nabila El-Bazel is the protocol co-chair for the HPTN 094 and a university professor at the Columbia University School of Social Work and director of the Social Intervention Group. Dr. El-Bazel is also the director of Columbia University Global Health Research Center of Central Asia, with main offices in New York City and Almaty, Kazakhstan. She leads a team of prominent faculty, scientists, researchers, and students who are committed to advancing solutions to health and social issues in Central Asia through research, education, training, policy analyses, and disseminating their findings. And with this, I would like to turn it over to Dr. Stephen Chaptal, who will now present the HPTN 094 study.
Thanks, Annette and Jonathan, and thanks to everyone for tuning in today. I hope to have a interesting webinar today. I hope also to generate questions from folks online. If Annette, you and Jonathan can read the questions that come in through the chat, please put them into the chat or into the chat. And if you guys could read them as they go along and interrupt me as I go along. I'm of that generation that can't do two things at one time. So it's I need a little help with that. But I think it's more powerful and impactful to answer questions as they come up. I also want to thank Dr. Nabila El-Bazel, who can't be here for the first part of the presentation today because she's doing another presentation, global webinar. So she'll be here a little bit later and will be available to us to answer some questions. But it's up to me today to talk about as we move forward. I'm going to be talking today about HPTN 094. I'm the protocol chair. Dr. El-Bazel is the co-chair, and we have an energetic group of people around us who are leading the world in how to respond to the issue of HIV prevention among people who inject opioids. This is an integrated strategies approach, and we're going to be talking a little bit more about that as we go along. Next slide. These are the issues we'll be talking about. We'll be talking about the HPTN. We're going to talk about HIV prevention in the setting of substance use and misuse. We're going to talk about opioid use in the US and what's been going on. Many of us know what's been happening. And we're going to talk about the HPTN study design, and we'll end with some acknowledgements and some questions. Next slide. So in the HIV Prevention Trials Network, we're going to talk a little bit about collaborators in the scientific portfolio, and we're going to start with, next slide, the depiction of the reach of the HIV Prevention Trials Network. As you can see, it's a very broad network. It's a worldwide collaborative of clinical trials, a scientific network that engages investigators, ethicists, community, and other partners to develop and test the safety and the efficacy of interventions that are designed to prevent acquisition and transmission of HIV. So it's actually, this is a mashup in this setting of this study of addiction medicine on top of HIV prevention. HPTN studies evaluate new HIV prevention interventions and strategies in populations and regions that bear disproportionate burden of infection, and it has 150 sites in more than 15 countries. Next slide. So the breadth of the portfolio is very wide. We recognize we're a long way from an efficacious vaccine and that no single intervention is likely to be effective for everyone. So that means that interventions for HIV prevention need to consider real-world practices that are appropriate and tailored for the specific setting and the group in terms of the socioeconomic circumstances and epidemiological characteristics. There is no one-size-fits-all approach. We need to increase our ability to respond to the needs of our participants. The HPTN research agenda is focused primarily now on the use of integrated strategies, taking strategies from different parts of medicine or preventive medicine or community to mix together to be effective in helping to prevent acquisition and transmission of HIV. This includes the use of antiretroviral drugs, both for HIV care and also for HIV prevention. Interventions for substance misuse. We understand that there can be transmissions that are linked to things that happen when people use substances, particularly injection drug use. And there are medications that can be used for addressing opioid use disorder. Behavioral risk reduction interventions and structural interventions. These are also approaches that we build into our protocols to ensure that what we're assessing is actually something that can be done in real world when we're done with the trial. The HPTN is committed to the highest ethical standards in its clinical trials and recognizes the importance of community engagement in all phases of the research process. And I'll also point that one other aspect of HPTN that is missing in many other scientific networks and even in science itself is the recognition of the need for diversity, equity, and inclusion at all levels of the research, from the participants to the clinics, to the staff, to the people who lead the trials. Next slide. So we're going to focus now on HIV prevention and substance use and how that works in the US among people who inject drugs. Next slide. So one of the major ways that people face risks for HIV among people who use substances is around the injection behavior, the actual acquisition, preparation of drug, the injection of the drug, the lack of care of where the injection happened, the abscesses that can form around these sorts of injection sites. We know that HIV is easily transmitted between people through shared injection equipment, as well as drug preparation equipment. We also know that hepatitis C actually is more infectious than HIV, and that often it's just a time to becoming infected when one injects opioids or other drugs in terms of getting co-infected with hepatitis C. That itself is a problem on its own, but together with HIV presents real problems for care and prevention of HIV. Next slide. Substance misuse, substance use, and HIV have also ways that can combine to transmit HIV through sexual behaviors. People who are under the influence of substances are more likely to engage risky behaviors This is a biological phenomenon, and it happens directly as a result of the drugs that people inject. We know that opioids actually work against the libido. So when people take opioids and inject them, they don't necessarily want to have sex. Now, they will have sex if they need to have sex to make money, to get more drug, or to have sex to have access to more drug, or to find a place to stay. But the issue of, the libido in opioids is actually reduced. So many people actually will, around the world, will integrate other substances that can shift that reduction of libido toward being more sexually interested, and these include things like stimulants. So we know that when people are using these drugs, whether for, and combining this with their sexual behaviors, whether it's anal or vaginal sex, that protection is often not available, whether it's from condoms or PrEP. And there may be other sorts of things that happen, like multiple sex partners or trading sex. Next slide. In terms of HIV prevention for people who inject drugs, there's a long standing protocol around the world that's used, that's been sponsored and developed by the World Health Organization and civil societies that talk about how to prevent effectively HIV transmission in this population. It packages loosely as a combined way of addressing harm reduction. And what these elements of harm reduction, there are 9 of them. I'm going to just describe them here quickly. Number 1 is access to needle and syringe services. Despite the fact that in the US, needle and syringe service programs are fairly politically not valued, these are very strong ways and effective ways of ending HIV transmission among people who inject drugs. And it also helps to increase the health of people who are accessing drugs. We want to ensure that people actually live through their injection drug use behaviors and find a different day when they can make other decisions about drugs and maybe move more toward health. To start or restart medications for opioid use disorder, I think it's very interesting that both access to syringe programs and medication for opioid use disorder are considered in the same HIV prevention policy. So we don't need to address and have our participants adopt the idea that they're going to get onto medications for opioid use disorder with the goal of drug-free status. We want to make sure that people have the capacity to stay healthy while they're engaging drug use, and include interventions that can range from needle and syringe programs all the way through medications for opioid use disorder while we're working with our participants. To provide HIV testing and counseling if people are HIV negative. This is something that the COVID-19 pandemic has greatly impacted. The idea of harm reduction for HIV testing and counseling has been greatly reduced by the COVID-19 restrictions. Antiretroviral therapies for people who are living with HIV, and test and treat for STDs regularly. Next slide. The 6th intervention for HIV prevention for people who inject drugs is to have condoms and lube available for use with new sex partners, to stay up to date on changes in drugs and HIV, to test, treat, and prevent viral hepatitis, and worldwide, much more important than in the US, is TB testing and treatment. Next slide. So what is opioid use and misuse like in the US? We're going to talk a little bit about this now. Next slide. So this is a picture of prescription opioids. We're actually in the 4th wave of the opioid epidemic. The current epidemic in the US for opioids, it's actually not opioid epidemic, it's opioid overdose epidemic. But a lot of people have increased use over time as well. But what happened in the late 90s and early the late 2000s and the 2010s, the aughts and the tens, that was the first phase of the opioid epidemic, and it was primarily driven by prescription opioids. At the time, physicians believed that pain was the fifth vital sign and that we needed to be aggressive in treating pain for people with chronic pain problems and backaches and other sorts of things, as well as cancer and that sort of thing. So physicians were much more likely to write prescriptions for opioids at the time because opioids are very effective treatments for pain. They are not effective treatments for suffering, however. So what would happen is people would maybe lose their jobs in the minefields or in the steel mills or in the labor, providing whatever it was that they were doing, and would turn to opioids as prescription opioids as a way to pass time and feel better. It caused a lot of opioid overdoses and was the first wave of the epidemic. What happened then was physicians shut down the prescription pad. This led to the second wave of the epidemic that started around 2012 and lasted to about 2014. As physicians stopped writing prescriptions, people who were addicted to opioids, maybe not even knowing that they were addicted, but got sick when they ran out of the medications, turned to heroin, a natural opioid derived from the poppy plant. Very kind to the body and a very effective painkiller. It's very cheap and available. It's on the street. And that's when people actually, there was an increase of involvement of injection drug use around the same time, of injection heroin use. So people moved from prescription opioids to save money. They moved on to opioids, and to be more efficient in getting opioids into the body, they injected. The third wave of the epidemic started around 2015. And that involved the increase of fentanyl use in the US. As fentanyl use, which started in the East and has moved all the way here to Los Angeles, what we see is people dropping dead at increasingly frustrating rates. That actually is the third wave of the epidemic, and the fourth wave of the epidemic we're currently in, and that's the combination of fentanyl plus cocaine and methamphetamine. These are what are contributing to the opioid epidemic. That is why people are dying. Next slide. This describes look at that dotted line. You can see just the number of people who are dying per 100,000 in the population related to synthetic opioids. That's that dotted line that's rising. It continued to rise in 2020, and in the COVID epidemic, what we saw was that people continued to, the highest rates of drug-related overdoses are being recorded currently, something like we've never seen. And we're going to see almost 90,000 people dying in 2020 related to fentanyl. Some people believe that the data that are longer than a year or 2 or 18 months old are so ancient that to understand what's happening in our country regarding opioid use, we really need to focus on these later data, which are largely unavailable, but are telling a horror story. Next slide. The horror story continues by thinking about the ways in which this opioid use epidemic is interacting with infectious disease, how the ways that HIV is being spread easily between people who are injecting drugs. One of the things I really want to highlight here is that in the US, for the first time, we see a stop to the reduction of HIV prevalence among people who inject drugs. Across the US, since 1996 and the development of active antiretroviral therapies for treating HIV, people who inject drugs has been a behavioral risk group where every year we've seen a drop in the prevalence of people who are living with HIV who also inject drugs. That has stopped, and that's been stopped now for the past 2 or 3 years. And in some metropolitan areas like Philadelphia, we're seeing the increase of prevalence, and actually we're seeing increase in incidence of HIV infection among people who inject drugs. Why would that be? Well, one of the reasons is because access to harm reduction has been reduced through the COVID-19 restrictions. So the idea about how to get clean needles, clean syringes, safe places to inject, the ability to provide opportunities for HIV testing, for STD treatment, that the things that we know actually pull together to prevent HIV infection, that those resources have been greatly restricted. And in the places where they are available, you can't get there. If you're living with HIV and you inject drugs, or if you're a person who injects drugs, and you're addicted to opioids or misusing opioids, what happens is you generally are not necessarily going to be able to hold down a job, which means that you're not going to have access to cash or to support to be able to, you know, pay the rent or get to places to take care of health needs. Because in the world of opioid use disorder, taking care of health needs is going to be on a level below making sure that you have access to use drugs so that you don't get sick. Opioids have a very profound opioid withdrawal syndrome that organize behavior very efficiently toward accessing more drugs so you don't get sick. It's worse than a bad flu, as I've been told. And the idea of avoiding that bad flu that would occur every 2 to 4 to 6 hours is something that organizes people's behavior so that they make sure they don't get sick. So the idea of maybe showing up at a needle exchange program that may be on the other side of town, which would require 3 buses and some transfers and a train, is not something that's going to compete well with the idea of making sure you keep your access to drugs available. So this presents the real way in which our people are living, especially in the urban areas, that we raised as we built this protocol. Next slide. One of the things that Dr. Nabila El-Basel and I talked about as we built this program was this protocol was to recognize the essence of how people are living who are affected by opioid use injection, and how that we can build a protocol that's going to ask some questions that are going to improve the health of people who are living with opioid use disorder and who are at risk for, who are living with HIV or are at risk for HIV. Next slide. One of the things I'm very proud about the HPTN is that for the first time since the establishment of the HPTN and from the initial HIV epidemic, we have a protocol here that is focused on people who are using drugs in the US. So despite the fact that we talk about the ways in which people who inject drugs are a major player in the HIV epidemic in the US, that our systems have, for lots of different reasons, avoided nationwide efforts to be able to address HIV within the drug use setting. So we can go back to all the way to 1985 or 88, wherever you want to put the line in terms of when HIV first started, to find the place that this is the first protocol. Super exciting. I'm very proud about it. And it really does focus on the injection drug use. Where we are somewhat weak, though, or flat-footed, is it doesn't inject HIV transmission in people who do not use injection drugs. So there are substantial numbers of people, in fact, many more people who use drugs that are living with HIV or facing risks for HIV who are using drugs that they do not inject. So that's something for a different day. Next slide. Dr. El-Basel and I thought, well, what we want to do is we want to set up a simple design. We don't want to be like going into our urban areas where, where we're working to be able to make it so that people can't really participate because it's too complex. So we got a lot of consultation from people who are living with opioid use disorder, people who have HIV, from public health departments, from people who are our colleagues, to find out how we could best address the question from a science base. And we came up with this simple 2-group study design where we're going to randomly assign 1-to-1, following consent, screening, and enrollment, in a mobile unit to receiving care, this integrated strategies care in the mobile unit versus a pure health navigation condition. That's top, and you can see that's where the road splits there with the truck. So at the end of 26 weeks, we're going to measure the effectiveness between the two conditions in terms of being able to keep people on medication for opioid use disorder and to be able to keep them on ART and or PrEP for HIV. And then those are the primary outcomes. And then at 52 weeks, we're going to evaluate people again to see what is the ability of this intervention, where it's delivered, to be able to help people to sustain their health. Next slide. So one of the questions that we have in the study is, how should healthcare systems change to meet the needs of people living with HIV or at risk who inject drugs? This is an important question, not necessarily, what intervention works better, but we want to be able to tell people in public health departments, this is the expected amount of change you can find by integrating a mobile care approach to a standard navigation approach for people who inject drugs in your metropolitan area. Here's how you staff it. Here's what it's going to cost. Here's what happens when you provide the services to people. They come or they don't come, or they come with an attitude, or there's a security issue. We're going to be able to have a lot of information around those sorts of issues. And then we'll delivery of multiple health services in a mobile unit supported by peer navigation, improve the use of medications for opioid use disorder, increase rates of viral suppression among people living with HIV, and increase PrEP for those who are HIV negative. Maybe I should stop right now just for questions before I move too much further.
You don't have any questions, Dr. Shoptop, so far.
Okay, then I must be explaining things very well, or else people are sleeping. So I'm just joking. Next slide. So we're going to ask some other questions here. How does this intervention affect HIV acquisition and transmission? So we want to know, what are the interpersonal things that change? What are the projected effects on other health measures and quality of life? Like, are people able to get a job afterwards? Are they able to sustain engagement in this activated peer navigation? If it's effective, what is the costs for the study, for the public health programs, and the intervention? Is it effective? One of the important things that we thought about as we pulled this study together was the issue of building a control condition. So it's very easy to think about using a mobile unit to be able to deliver these integrated strategies. That's the easy part. But the harder part was, well, what is a control condition that we could use to be able to say that this mobile health unit will provide more effective interventions compared to what? Across the US, what we know is that people who inject drugs have very little available resources. So often in doing trials, you would take something like you put a mobile unit and then you combine it and with whatever is available in the background and test it against the idea of what is there that's just in the background. So giving that sense of, this is where you start and this is where you would increase the effort. What we found was that in the 5 cities and many cities across the US, there is no available level of care for people who inject drugs, period. Whether it's about medication for opioid use disorder or whether it's about HIV care or prevention, it's just not there. So we had to actually build a control condition that says this is enough so that if you actually get assigned to the control condition, that we don't come up with an ethics issue in terms of favoring a condition that we believe is going to be powerful compared to a straw man condition where we're just going to be like, sending you to this condition and you're going to get some outcome, but then nothing good will come of it. So we built this activated navigation condition that comes along with both conditions will access. The control condition gets the activated navigation, peer navigation, as well as the mobile unit experimental condition. Okay, next slide.
So we do have one question if you want to just hold for a second,
Sure.
because I know that you want to respond to questions in real time.
Yep.
One of the questions that Jess was sent to us is, how will the target populations be engaged and what will be done for their partners and others, such as those who do not inject but use opiates by other means of administration?
That's a really good question. One of the ways in which we're responding to that question is to engage cabs at each of the sites, recognizing that each site will have a different background in terms of what's available for people when they come in. So if somebody is coming in and their partner or themselves, they're not injection drug users, or they don't use injection drugs, or if they do use injection drugs, but primarily use stimulants and sometimes use opioids. The question is, what are we going to do with those folks? That's something we have to focus on, and we're working on actively right now. We're just getting into the field. So we're kind of figuring out those questions. One of the things that we're doing in terms of people who come in and who are partnered is that we actually have decided that we will randomize them to whatever happens. So they'll get randomized separately, but they'll be a partner. We had a lot of discussion about how we would manage that, to be able to manage how people come in together, because often people will be partnered and will want to participate together. So we're just going to let the random assignment take care of it, and we'll watch it as we go along. Annette, does that capture most of the question?
I think it does. And another piece to the question was, because you mentioned earlier about Hep C. So this person was wondering how you're going to be integrating HCV testing and treatment along with the other interventions laced within this protocol.
Great question. So we will be testing everyone for hepatitis C during the screening process. And at that point, we will find out their hepatitis C status. We discussed this during the building of the protocol. What we're going to do then is begin a discussion with participants, and we'll highly recommend that they begin treatment for hepatitis C within the setting. So one of the ways that we're going to do this is, we know that in 4 of the places where we are conducting the study, we are conducting the study under the Medicaid Expansion Act. So that allows people to have access to medications for opioid use disorder, as well as hepatitis C treatment under the Affordable Care Act. One of our sites is in the South, in a state that is not Medicaid expansion. So there's different levels of and different kinds of resources for treating hepatitis C in the southern site. So we have opportunities to see how we can best manage hepatitis C within the southern location. Where we're doing this work in the South is in Houston, where there are a lot of foundations that support providing the costs for care for people who have medication for opioid use disorder. They'll provide the medication care costs somewhat, but also will also provide access to hepatitis C treatment. I appreciate the question. And as we roll out and move forward, we'll be having more discussion about how this moves it forward. Now, I do know that just knowing that one is hepatitis C positive does not mean that one's ready to begin treatment for hepatitis C. And that has to do with the rank ordering of problems that people have energy to address on a daily basis. To treat hepatitis C means taking medications every day for 8 weeks or whatever. So the idea here is then, for some people who are ready to start that intervention, we absolutely will make the bridge to the available resources so that they can start the antiretroviral therapy and move to hepatitis C negative or cured. But for other people, that may not be as relevant an issue, and it may be more important to them to have other things managed before they begin starting a course of treatment that requires daily medication taking and clinic visits. So it's a great question, and we're on top of this, and it's an active part of our discussion. So I love this question.
There's another question, but it might also be a question or a topic that you're going to talk about later on. So what the question was, what arrangements, discussions have occurred with local law enforcement to ensure participant safety? And I don't know if you want to talk about that in terms of site specific or protocol in general.
So let's talk about it now, because that is an important point. And, as we're talking, these questions are pointing to the sensitivity that's involved in being able to get this protocol launched in a way that's safe for our participants. So one of the things that each of the sites has done is developed relationships with the parts of the police department that are willing and able to work with people who inject drugs, and to be able to provide knowledge about where we're going to be so we don't get harassed. We know that a cop car that's parked adjacent to the medical unit is going to stop people from stopping by. So being able to work out relationships with the police so that they do not use us as a lure to get people popped for warrants or other sorts of things, or just harass participants. So we have discussions ongoing. Each of the police departments have units within them that deal with these community-based issues, and we are actively engaging those as we go along. And as we do this work, we're having implementation science being collected so that we understand how each of our communities may differ across the 5 sites in terms of police involvement, access to healthcare, being able to access transportation or housing, food security issues, those sorts of things that involve the whole person, that we'll be talking about how those resources are or are not available, and be able to document this, and where those resources are, if they are available within these geographic areas. So great question. So next slide. So we kind of went over this a little bit. So we have the mobile unit, it's group 1, or our experimental group, where they receive healthcare services on the unit with peer health navigation, versus the traditional unit, our control condition, our active control condition, where they get initial screening and enrollment at the mobile unit and transfer onto the active peer health navigation. Next slide. So the peer health navigation is very active, and I talked about how we needed to build this because there are no available naturally occurring supports for people who inject drugs. So what we built this to do is to be built on 5 different models within social, with interventions, with the idea of building in self-determination theory, decision-making, in terms of being able to do self-affirmations. We have all kinds of ways that we reinforce the participants' autonomy in making decisions about what they want to address at any point in time. Dr. Elbasell is our leader and our expert in this area, and she'll be joining us in a little bit, and we can ask some more questions about how she came up with this integrated strategy. But it's all based on being able to reinforce the participant as autonomous, and that's based in both of our understanding that people who inject drugs often can still pay the bills, can have meaningful family relationships, and in all other aspects, maintain very competent living skills. So we want to reinforce the ability of people to choose and to make those choices in real time so that their health is being maintained. We in this study, for people who are in the medications for opioid use, the mobile unit, they will have access to medications for opioid use disorder at the unit. So we will actually be providing oral daily buprenorphine with linkages to methadone if that's what people want. We won't have methadone on the unit, but we will have it on the unit for people who are assigned to the unit. For people who are in the active control condition, people will be navigated to providers within the community who will write prescriptions for buprenorphine. We're going to provide people, all people, naloxone reversals. Naloxone is an opioid antagonist that is used broadly to reverse heroin or opioid overdoses. So we'll be providing naloxone kits to all participants to distribute to their close circle of friends with instructions about how to reverse an overdose. We'll provide people on the unit HIV, HCV, STI, STD testing and treatment, excepting, as I went over, we're not doing any treatment on the unit. But we do have a generous donation from Gilead that will provide Biktarvy on the unit for HIV care. And we also have a generous donation from them for Descovy, which is TAF. It's the new PrEP medications. We're going to retain participants. The goal of peer navigation is to retain participants in substance use and MOUD treatment. We want to make sure that people stay in treatment. And the reason for that is because when you stop using treatment, in the absence of a stable social, spiritual, physical health environment, what happens is people will migrate back to active drug use. And that's the nature of addiction. It's not a problem with people. It's the nature of addiction, that addiction is a chronic relapsing condition. And so what we want to do is be able to have access to people so that they have access to sterile drug use supplies when their addiction is active, and to provide very easy, low barrier access to medications for opioid use disorder when they're engaging in treatment. I did see, and I saw a question come in about the difference between methadone and naltrexone or naloxone.
Yeah, naloxone is a short acting. In this case, do things. Methadone is something about, is methadone a better option since it's long acting as opposed to, I guess, buprenorphine. And then there's another question about integration. Will there be a referral to mental health care services where any point of care for mental health considered should be provided through the mobile clinic? So I think there's two questions. One is to talk about naloxone as a short-acting medication, and thinking about methadone, why methadone is not a better choice, I guess, than buprenorphine, and then the issue of mental health care referrals.
Sure. So very quickly, those are great questions. So naloxone is not treatment. It is actually included here as an opioid overdose reversal treatment agent. So the idea here is we don't want people on daily naloxone. There are injectable naltrexone that's available called Vivitrol. The reason why we're not engaging the use of Vivitrol is because often people will, it's a 28-day medication. You give people the injection for 28 days. For 28 days or so, people will not use opioids because it actually protects against them getting high from using opioids, because it's an antagonist and it occupies the receptor sites where opioids bind and cause their happy reinforcing effects. So people don't get the effect. So for 28 days, people are blocked, but on day 29, what happens is people will generally take their dose of opioids. They'll have lost their tolerance, meaning that they, won't be able to tolerate the typical dose they had before they stopped using. And often that's a point of overdose and death. So we really want to avoid that sort of approach. We want to focus people and point people toward agonist approaches, and these are buprenorphine and methadone. Buprenorphine is a daily medication that we're asking people to take, and so is methadone. We can provide buprenorphine on the mobile unit. It's also more available in the community more broadly. And we're recommending people who will do buprenorphine to go on to buprenorphine. We are slow to recommend people going into methadone, and there's a reason for that, and that is because traditionally methadone has been used for people who are of color and poor SES, whereas buprenorphine has been primarily given to people who are of dominant culture, white, and more wealthy. So what we want to do is to increase access to buprenorphine, because buprenorphine can be treated using an outpatient primary care provider. It doesn't limit people's lives. You don't have to go to a narcotic treatment program to get dosed with the medication. And it opens up the ability to more quickly engage a healthy life. So that's why we really are focusing toward bringing people onto buprenorphine if that's available to them. We want to make sure that people have access to mental health as well. So as part of peer navigation, we'll be providing some brief counseling, sort of, but not really, because these are peer navigators, with links to counselors, to medications for methamphetamine use disorder. We have some new ones on the market that have shown some efficacy, so we'll be looking at that. We'll be looking at getting people linked up for depression care, for other substance use disorders, for intimate partner violence. All those sorts of things we'll be making linkages to. We'll be providing reproductive health services for women, so we'll have linkages to people so that they can get reproductive health care interventions for women. And also because we know that people who inject drugs often have involvement with criminal justice, we'll be making links to legal support. Next slide. So what are we going to do in the mobile unit that's different than the navigation? So we're going to diagnose, manage minor illnesses and infections. So, when people come in who may have lost, it's often the case that if you're living close to the street, if you have insulin for your diabetes, you can get rolled and your medication stolen. So the idea of being able to write another prescription to replace that insulin can be very important. Prescriptions for illnesses, infections, identify more complex care needs and referrals for available community services. I do want to say that this is amazing that this is available. One of our first participants from Philadelphia showed up with an abscess on their neck, meaning that they had been injecting centrally into the veins here in the neck and actually had developed an abscess. And one of our peer navigators says, I know that I'm supposed to let you set the stage and tell you what you need to do, tell me what you want to do, but you need to take care of this. And actually got the person into urgent care and was hospitalized for the care of that abscess. So there is, this really wonderful way in which this integrated strategies approach of being able to see the person more than their addiction is really going to help change lives. And in this case, may have saved this person's life.
Dr. Chaptel, I think that that's a really important point to emphasize, because as you talked about harm reduction earlier, is that is harm reduction.
Yes, it is.
Because harm reduction is truly about saving people's lives and
It
in
totally
humane,
is.
respectful, milieu. And so I thank you for talking about that.
Absolutely. And I mean, this is where you can tell my heart swells. I mean, this is really wonderful work. Nabila and I have designed this protocol, and the people who are engaged with this protocol are fully bought in. Not only the investigators of record at the sites, but also HPTN and NIDA and the NIAID networks. I mean, everyone is super excited about this and this approach.
We do have another question.
Yep.
How and where are subjects recruited for the study? And are they going to the treatment clinic for HIV, Hep C services and or drug treatment services?
That's a great question. So to get into the study, you have to be out of treatment for medications for opioid use disorder. So we're looking more to the streets than to the local, narcotic treatment programs. Although we have links to those narcotic treatment programs, and people who are having trouble staying in treatment can come. But generally speaking, we're doing some surveying of the communities in terms of where people are who are not in medication for opioid use disorder and are using opioids. So each of our 5 sites have spent a very energetic and sustained observation of clinics, of areas, of looking to the public health departments, using local data to begin to understand where people might be who are injecting drugs and how to find them. As well as the issue of going to HIV care sites. One of the things that we know is that people who are dependent to opioids, they're often not careful about their HIV medication taking. So what they'll do is their HIV disease or associated infections will land them in the hospital. So we're looking to make sure that we're staying in touch with points of care for people who have infections or other sorts of problems as well.
If you want to speak a little bit more about recruitment strategies in general, because I know every site will have their own recruitment strategy protocols, but there was a question that was asked about how sites will be recruiting people from the streets and what's the safest and possible way to do that. And again, I know from my experience that that's very site specific, but perhaps you could just share some general strategies and philosophy.
Yeah, so, from self-determination theory, we know that people are not going to pay attention to something that has no meaning to them. So in each of the sites, there's been discussions with people who use drugs about what's important to them. So one of the things that's available that's important are things like clean injection supplies, sterile injection supplies, and being able to provide harm reduction aspects of things, elements of harm reduction to people, being able to have food and to have water for people who show up at the unit to find out what's going on. So, that's the essence of where we are doing our recruitment, not necessarily to go beat the bushes, which we are doing, but the issue of having something that's of value to people, that they would actually come and talk to us and consider engaging this study. So that also is a major piece to this. And you're right, each city is different. So, if you're talking about the Kensington neighborhood of Philadelphia, that's very different than the wide expanses in Houston and Los Angeles. So, in Los Angeles, we're starting recruitment, not in Los Angeles, but we're starting in Long Beach, because for whatever reason, the overdose opioid deaths rates are highest around the Port of Los Angeles. So that's where we're starting. And as we go do the study, oh, I see Dr. Albacell has joined us. Great.
Yeah.
So Nabila, we're talking a bit about the recruitment strategy at this point.
I wonder if I can add one piece to what you said, Steve. I fully agree with how you described, but there is another important piece that Steve and I paying attention to in how we ensure that communities of color are aware of and have access to the study mobile unit. This is really an important piece, and how we ensure it by data-driven approach, by collecting data from a landscape analysis from the early stages of the study about the neighborhoods in terms of Latinx, Blacks, how many people are in each neighborhood to ensure diversity. We are even digging into the number of services for HIV or for MUD in each community, and ensure even how the services that are provided in the community are culturally competent in terms of HIV or MUD services. We're asking providers to give us data about their perception about how culturally competent the service is. So we're really collecting data to make sure we're getting to neighborhoods that they need the service.
Great point.
Yeah, and perhaps also talking about the peer navigators having lived experiences themselves, and why that was important to hire peer navigators who could, really share lived experiences with potential study participants. And
so I'll let Nabila manage this. This is her area of expertise. It's a great question.
No, it is a great question. And from the early stages of designing this study, we pay attention to this issue. And we recruited the navigators from the early stages, navigators who have a lot of experience in the field and with lived experience to give us input on the protocols that we design in how navigators deliver the services. We also created training protocols on how to manage stressful situations when the navigators face in real world settings. And really, to tell you honestly, the most really relevant and powerful piece for us in the training is the people with lived experience who are navigators and provided us with strategies to ensure they get access to the knowledge they need, but access to really support during this process. Each navigator also has a supervisor. We created a module on how the supervisor of the navigator work together to address not only the implementation of the intervention itself, but dealing with really tough situations that the people with lived experience who are navigators faces. In fact, we also capturing scientifically the whole process in order to improve at the end of the study how we can package this kind of intervention. But the most helpful thing was really the input from the people with lived experience who have been navigators for many years.
And if I could add a little bit to what you're saying, Nabila, I mean, one of the things that's important here is this is a major departure. This whole protocol is a major departure from science as usual. So we're focusing not only on peers who are, lived experience of opioid use disorder, but we're also working on aspects of infectious disease, HIV care management, HIV prevention, because our participants are not just living with medication they're not just living with opioid use disorder, they're living with HIV or are living with HIV risk on a regular basis. And, we want to, as Nabila was mentioning, this whole issue of competence is not just about being able to do something other than refer to 12-step, but is actually able to understand that people in real time are more than an addiction, or they're more than people living with HIV. This comprehensive, holistic approach that runs through the protocol from the top to the bottom is really it's not really it's essentially groundbreaking. Okay, next slide. So we have we've kind of gone over this a good amount. We're going to be doing 6 months of treatment on the unit. This is the unit that's available in Philadelphia. And the peer navigators will be around for 6 months, whether they're in the mobile unit or in the active peer navigation condition. And after 6 months, all care will be transitioned to ongoing care at bricks and mortar clinics. Next slide. Where available, by the way. This is the traditional clinic, the peer navigation group. Again, they'll have 6 months of peer support. Here are the participating sites. We have in Los Angeles, starting the left coast, the best coast, Los Angeles, Dr. David Goodman-Meza at University of Texas. Dr. Arduino is actually the CRS leader, but the leader of the trial is Jordan Lake. If we go to Washington, D.C., we can see that Irene Kuo is the leader at George Washington University. David Metzger is at University of Pennsylvania. And Jessica Justman started as the IOR at Columbia, but at the Bronx, but it's now Ellen Morrison. So next slide.
So before we go to the next slide, and I don't know if you're going to address this or not in the next slide, but there was a question about the issue of the criminal justice system and how, in fact, there has been, consideration or discussion around managing participants cycling in and out, perhaps, of, in either incarcerations or being detained and receiving, the care, like the buprenorphine, and how that might be handled.
That's a very broad question. That's a very large question. So I'll dismantle some of it, and maybe Nabila can step in. So we had discussions, first of all, about what to do about engaging people who were involved with the criminal justice system. And there are decisions that have to be made based upon, engaging people at different levels. What we decided was to allow people who can sign into the protocol who are on parole, not probation. So the idea of having active criminal justice system involvement with an active trial or whatever, or a sentence, you're out in community, would not be something we can support. But if someone's on parole, we can, because that means that the court is just, they've terminated their supervision of the participant, and they're not engaging ongoing supervision. We did that as a decision to provide the most freedom to people, so that if they were to not do well in our protocol, then that information would not necessarily be used against them. It also has to do with ethics issues and the increased amount of engagement of an oversight of the IRB in terms of how we run things. But it is an important question, and we will engage people as long as we can, recognizing that this is a chronic relapsing condition, and people will go back in through the criminal justice system, and we'll be there to support them and to engage them at all the levels. Nabila,
you covered what we are planning to do, but I also want to highlight that in our first deliberation about where the van should be, we wanted to make a data-driven approach, meaning that we really need to study for every state that is involved in the study to define based on the data where the van should be. And in some cases, we had a discussion around putting the van close to jails or prisons or community supervision programs in order to link people immediately to care, to come to the van and receive what they need from medication for opioid use disorder, and also have access to naloxone medication to save lives. And because we know it's really living in jail or prison is the most really high risk situation, and people need to be accessing naloxone and being linked to care. It's also really the best time to link people to care. So in many cases, we will be really seeing people who are coming to the study that were released from jail and prison and people in community supervision, and we will deliver the same intervention that we deliver to everyone in this case. Also, the navigators, as well as the project directors and the team, are aware of how important to engage people, especially upon release from jail and prison. And clearly, the strategies for engagement may need to be more really immediately delivered and be strong in order to engage people in treatment and care, because as we know from our work and from the research, people who leave prisons and jails are more likely to go back and because of the no really linkage to care. And this study is really would be a good opportunity to link people immediately to care.
We also have another question that has just been submitted, and this has a focus on any services for trans persons who are sharing and injecting gender-affirming hormones, as well as injecting opioids.
So that's a great question, and certainly it's something we worry about here in Los Angeles. We believe that a large, a substantial subgroup within this larger group of people who inject opioids will be transgender persons. One of the things we will provide is, obviously access to sterile syringe equipment. But we also are very closely affiliated with the providers of hormones and transgender specific services within the Los Angeles County region. We link many of our one step removed colleagues are people at the Transgender Wellness Center, and being able to get folks into access to hormones is seriously a major issue, and we will work very tirelessly to get people engaged in competent care. So that's a great question, and we certainly will be working with that. Okay, shall we do the next slide? We're getting to the end here. Study population. We purposefully selected people of majority at 18, and we set the limit at the upper limit of 60 years. And the reason for that is because people who are above 60 years of age, and no offense, because I'm one of them, but sexual risk is not at the high end of the list. And also what ends up happening is people 60 and above tend to use less opioids or use in ways that are less likely to be at risk. So that people have opioid use disorder and be injecting drugs, willing to start opioid use disorder treatment, but not currently in treatment. So if people are actively in buprenorphine or methadone, they would not be qualified for the study. We're looking for people who are experiencing being out of treatment at the time they engage the protocol, to be at risk for transmitting or acquiring HIV, and to be HIV negative or positive. It's status neutral protocol. Next slide. Study population, we're going to enroll 860 participants at 5 sites. We are in the field in 4 of 5 sites right now. We're on the hook for 460 people living with HIV, about 100 per site, and 400 who have not acquired HIV. We have set the limit of 25% minimum. It's the floor of being women, and the reason for that is because women are traditionally excluded from substance use research trials and substance use care and all kinds of other kinds of care that the women find it very difficult to engage treatment. And we're also setting a bar for 25% younger than 30 years. And the reason for that, again, is that these are folks who are engaging risk more energetically and have more risks for HIV acquisition or transmission. And we want to make sure that we are able to bring these folks into the study. Next slide. Okay, I think we're at the end of the slide deck here. Are there other questions? It's been wonderful. I do want to acknowledge that I'm very grateful to the HIV Prevention Trials Network, as is Dr. Elbasell. NIAID has been very generous. Office of the Director, NIDA, who is funding this protocol, has been incredibly helpful in IMH. And also really want to do a shout out to Gilead, who is providing Biktarvy and the PrEP medications. So thanks, everyone. Next slide. Questions?
I'm not seeing any additional questions. Please, if you have any. Oh, here's
There's one.
came
thank
in.
you.
Wanting to know, they said may have missed this, but is there a plan to oversample HIV people living with HIV?
Right. Yeah, great question. Yeah, we are out. We do have we are sampling a little heavier in the HIV positive group, and the reason for that is we want to be able to model the impact of this intervention on disease, the potential for transmission in communities. So we have slightly more people who are being engaged in the protocol who are HIV positive than HIV negative. Yeah, it's a good question.
Yeah, and another question is, I would like to know more about how the peer navigators are trained. Is there any form of certification before they provide services, and what is the scope of services they provide?
So I'll let Nabila fill in the training aspects, but yeah, we did a lot of training with folks, and it was mindful and prospectively designed. Nabila, you want to?
Yeah, I think we provided an intensive training for more than a week and a half, where we introduced the protocol, from more the content of the protocol, the theoretical conceptual model that guided the protocol. And we also provided training on the supervision of the navigator. And in terms of the certificate, I believe we have not used a certificate at the end of the training. Correct me if I'm wrong, Steve. I don't remember.
I think you're right, yeah.
We did not provide the training. However, the good thing is that all the training recorded, and the new navigator can watch the training that he provided during the 2 weeks, approximately 2 weeks. Also, we meet with the navigators on at least twice, with the supervisor of the navigator at least twice a month, and get their own input about the implementation of the model.
We also have ongoing training. So every month we have different topics. So we're starting with motivational interviewing, but we have gone through other ones as well, and we'll continue to provide advanced courses on training for people who are the peer navigators.
And we have another question. Are you planning to evaluate the changes in the HCV risk dynamics and treatment engagement as a result of your interventions?
So we have a number of secondary outcomes that we'll be following, and hepatitis C engagement in terms of activity of engaging treatment once one is aware of one's status is one of the issues that one of the secondary outcomes we'll be following. So we will be looking at that. But we'll also have this broader contextual information that's collected as part of our implementation science work, where we'll understand what is available if you do find out you're HCV infected or HCV positive. What is the likelihood that you could find affordable care for treatment, and what kinds of support are available for people who are undergoing that treatment. Excuse me. The short answer to that question also is that this is such a rich protocol because we are measuring aspects in as short a way as possible, because we need to be brief with our assessments. All of the aspects of the integrated care strategies. So we expect that some people, medications for opioid use disorder may be not as important as maybe accessing housing or food security. And there may be people who have different perspectives on hepatitis C treatment timing in their life course. And some people who may be more or less interested in like not using opioids on a regular basis, or addressing issues around stimulant use, being able to manage their relationships. Yes, and Sam mentioned we will measure the difference between incidents during the two treatments, the two conditions.
Yeah.
You know, I think this is a very rich protocol. I think it is addressing so many issues that confront people who are injecting opioids, injecting substances. And you talked earlier about disseminating what you learned to care providers. And I wonder if you are, you know, how in fact you see actually being able to share the information with perhaps groups of providers who have sort of dug in their heels and been reluctant to hearing about how we can be more innovative working with people who inject substances.
Well, now that's a superb question. So thanks for that one. You know, at this point in my career, I'm old. So, you know, one of the things that I have learned is that people don't make decisions about what's available in policy based on data, but on their own religion. So people have ideas about what kind of care people who inject drugs should merit. And that can be different by where you live. In California, we're lucky to be here in Los Angeles, where we have a very progressive public health department who is like talking with the investigator of record, David Goodman-Meza, on a regular basis every other week to talk about, you know, what's going on in the background in terms of opioid use and stimulant use across the county. What about, how do you go about staffing a mobile unit? And then following that up with buying 2 mobile units and asking us, well, how much physician time, how much, you know, NP time, these sorts of things. How do you staff this on an ongoing basis? So I think I have 2 parts to the answer, and one is, you know, Dr. Elbasell and I are both firmly committed to each of the sites being engaged in an integral way with the public health departments, recognizing that conversation can change minds. And so we're kind of not only like trying to wait until the final paper comes out, but also talking about the people, the deciders, the clinicians, the public health people, to shift change as we move along, to start seeing people with opioid use disorder as humans first, and to begin thinking about ways that we can keep our people alive so that on a different day, they may be fully tax-paying and homeowning or whatever that is that they want to do that fits more closely with broadly held dominant culture beliefs and values. So that's the essence of the impulse here, is to create space for people to live today, you know, so that they can go on and be productive members in whatever way they define that to be, you know, and that our society broaden itself to think more about how to engage care among those who have the least.
Thank you. And the last question of the afternoon is, Will you assess any outcomes on peer navigators? For example, their own mental health status over time, physical and mental health services used, training needs over time, minimal level of qualifications for being a successful peer navigator.
Wow.
Yeah, wow.
It's the last question.
Yeah. We are collecting data on the qualifications of the peer navigators, and we are collecting data on really challenges that peer navigators face, and we are collecting qualitative and quantitative data on barriers of implementing the intervention, but we are not collecting data on the mental health of the navigators and the impact of this work on their mental health. But that's a really good question. So we should go back and think about this issue.
Yeah, whoever wrote that question, I see it was Vicky, was she knows what she's talking about. I mean, the issue of peer navigation is very important, and this isn't just, you know, referral to 12-step or how do you best get to 12-step or how do you get to drug-free. This is really, these peer health navigators are remarkable human beings, the ones that I've met along this way so far. And these are folks who do have space in their brain for imperfect response from the people they're working with. And that is an important point, that, you know, imperfect response is something that can be hurtful or, you know, it can be hard to integrate into how you see yourself as an interventionist. And it requires a little bit of work, which is why we have the support, we have the supervision, we have the ongoing discussions with folks to have our feelers up so that we are always assessing for that kind of to address burnout before it happens, or to be able to engage people to make sure that they're not getting in over their heads with a particular participant or over emotionally involved. So these are important points that are raised, and we'll write more about it as we go along for sure.
So thank you for such a rich presentation, a rich protocol. It's exciting and certainly innovative, and we have work ahead of us and lots of information to collect, lots of sharing and caring to provide. So I want to thank everybody for joining today, and Dr. Shoptalk, Dr. Alpazel, thank you so much for putting this protocol together and for this terrific presentation. Anyone else want to chime in before we close the webinar?
I didn't get to say it, but, you know, the leadership group has been really supportive. And when in doing the acknowledgements, I forgot to mention all the many people who are affiliated with the HIV Prevention Trials Network and FHI 360, particularly Sam Griffith and Phil and Andrews. The issue of you know, these guys have been incredible advocates for this protocol and have helped us get into the field as quickly as possible with the highest level of science. Just seriously, Nabila and I are both very grateful for the internal support.
Absolutely.
And thank you, Annette, for leading us through this today. You know, guiding it. We appreciate it.
My pleasure.
I think that's it. So thanks everybody for joining. We'll sign off now and look forward to the results of the protocol.